rates, etc. So this is part two of the presentation for the international study. Yesterday we presented the results of the preliminary analysis. 5 of the 10 countries in our international study were presented. We have 3 that are currently entering their data, and I will analyze that in the next couple of months, and we will present the final results in Antalya, Turkey, October 28th and 29th. And we will talk about that more in the second half of our time together. This session, we will present how participants of this international research collaborative have used data to study their own context, and how these data from these studies have helped to build the model that we tested in this study. We will also talk about next steps for our collaborative work together. We will present research from Scotland groups and how they used unit-specific reports to develop interventions for improving the relationship with the physician and coworkers. We will also look at how they identified and measured specific aspects of operations that helped to implement a framework of caring that was called the Caring Behaviors Assurance System, and we'll talk about that a little. Finally, we will look at how Scotland developed a measure of caring specified for Scotland, because neither Watson's theory nor Swanson's theory of caring was found to be valid for the context of Scotland. After Scotland, we will look at how our research colleagues from Turkey measured the work environment in both 2017 and 2018 using the HES, which measures job satisfaction. We will also look at how they used qualitative data to examine for possible dimensions of job satisfaction that had been overlooked. Next, we will look at how Jamaica tested clarity first. We found in our international study that it was an important variable, and Jamaica was the first one to examine that, and we'll talk about their research and how they conducted a confirmatory factor analysis of the HES. Lastly, we'll look at a couple of organizations in the USA that examined caring science. The first is a 96 hospital system, Trinity Health. They measured a model of caring using multiple different theories in caring. St. Joseph's in New Jersey also looked at caring science. And finally, Henry Ford Wyandotte in Michigan, USA. This is the agenda for our time together. I've given you the introduction already, so we will jump right into how we are building the science globally. And then we will move to predictive modeling, which I'm very excited to present to you. We will be using a falls study and a hospital-acquired infection study that we did, and how we use predictive analytics to save millions of dollars and improve outcomes dramatically using these mathematics. And it is my dream to be able to integrate behaviors like caring and clarity and how that adds to these outcomes. And then finally, we will look at next steps and discussion. There were 19 staff on the unit in 2014 and 24 in 2016 that we studied in Scotland. And we found that it was 100% of the staff who responded on both of those years, which was really good and useful for discussion with the staff, because we did present the data to the staff and discussed what it meant. What was so distressing for them is that their scores really fell from 2014 to 2016, and they were just awesome staff and clinical workers, but it was a difficult discussion about talking about some of the distresses, and the primary one was the relationship between the staff and the physicians. And there were 3 of the variables that were actually below 4.0, the midpoint on the 7-point scale, indicating that there was more dissatisfaction than satisfaction, and 9 of the 11 variables had actually declined, and there was a statistically significant difference in that change. So it is not always easy to talk about the data, but we can't change what we don't define. So having data to use to direct a conversation that wasn't on the subjective but on the objective was very helpful. These are their scores, and you'll note the solid blue lines are the 2014 scores for all of the dimensions of job satisfaction. And the diagonal striped white and black are the 2016 scores. And you will note that for every variable, there was a significant drop in those scores. And remember, this was 100% of the staff that were responding. You will also notice in the subsequent 2018 measurement that the scores dramatically improved. That is because in 2016, when we presented the data, interpreted the data, and created an action plan for improving the relationship with the physician, it not only improved the relationship with the physician, but there was a statistically significant improvement in relationship with coworkers as well. So the change from 2016 to 2018 was statistically significant for the relationship with the physician. The P was 0.048. And for the relationship with coworkers, the P was 0.007. So they were very pleased to see that their efforts paid off. And if you have questions, don't hesitate to interrupt me, but otherwise, if you can just mute your microphone so we don't hear any background noise, that would be appreciated. But don't hesitate to interrupt me if you need to. Here in Scotland also, we wanted to understand why their framework of caring caring delivery, the caring behaviors assurance system, we wanted to understand why that was so impactful. Just intuitively, as we were implementing or watching the implementation of this system, we could sense that the work environment and job satisfaction was improving. And I won't take time to go into detail about this model. It was developed by Janine Bywater-Sweetam and Dr. Susan Smith. They are based in England, and I have noted Choice Dynamics link to that company that oversees this framework of care delivery. But in this hospital, Golden Jubilee, which is by Glasgow, they had sensed that the work environment was improving, and we wanted to understand why. We attended a small gathering of researchers that included researchers from the University of Stirling, and Dr. Brian Williams had identified in his research that they found there were units that were very successful in implementing CBAS, and there were units that were not successful in implementing CBAS. They utilized Gaussian mathematics and stated that there wasn't a significant change, which was not our experience. So in looking at the profile of success for the units that did very well in implementing CBAS and the units that did not do well in implementing CBAS, Dr. Williams articulated 6 variables that he called the profile of success, or something like that. And so we decided to use those variables that Dr. Williams has identified as important operationally to address when implementing CBAS. We wanted to see if it did make a difference empirically, so we wanted to build on his research. The 6 dimensions of success included staff frequently speaking with CBAS facilitators during implementation of the program. That was the first dimension. Secondly, that the facilitator was sufficiently trained to trigger behavior change. Third, that the staff perceived CBAS was relevant for their ward. Fourth, that their senior charge nurse, which is what we would call the unit manager in the US, their senior charge nurse was inspiring as it related to CBAS. And use of the patient-centered care quality instrument called the PCQI was understood and used routinely, and they usually responded to it. It's like an audit of the CBAS system, and they usually do that about every 6 to 12 months. And those were the things that were identified as important. So we studied these 6 operational aspects that were reported to be important. We created a 17-item survey, and we found that there were 5 variables that had a very significant relationship with job satisfaction as measured by the HES. And this resonates with Dr. Williams' findings. We found first, the senior charge nurse I work with inspires me to apply what I learned during the CBAS training within patient care. And they would use the 7-point scale from strongly disagree to strongly agree. And we found that those who had inspiring senior charge nurses had higher job satisfaction, and those who did not had lower job satisfaction. We found that senior charge nurse is part of the support I feel is helpful to successfully implement the action plans we delivered in the CBAS training. There is enough resources for me to feel we will be able to implement CBAS action plans on my ward. Executive leaders are supportive of the change agenda that comes from our team action plan, and I feel there is adequate time for me to do what I feel is needed to implement our action plans following the CBAS training on my ward or department. So we identify that this did have a very strong relationship with job satisfaction, and here is our final regression looking at not only job satisfaction, but how that impacted caring and quality. I don't recall the exact, but it was several hundred of staff that were in this analysis. We found that the measurement that we called the operations of CBAS predicted 40.7% of job satisfaction. We also find that there were certain wards that embraced the concepts of CBAS and the operations of CBAS, and we found that through ward, operations of CBAS also had an impact on job satisfaction. That was 6.4. Found a direct relationship with ward, that there were some wards that just were better at implementing it regardless of the operations of CBAS, and that explained 14.7% of the variance. Combined, we were able to explain 61.8% of the variance of what predicts job satisfaction as it relates to ward and CBAS. So as you can see, implementing a framework of care is important, but monitoring the operations of that implementation may be even more important. It is not just time that will show you if there's been an impact, but it has to be the operations of that framework. Finally, we see that job satisfaction with implementing CBAS had an impact on caring and quality as reported by staff. So staff who feel they have the social and technical dimensions to do their job were more likely to feel connected to caring and quality as it relates to patient care. That predicted it was 14.1% of caring and quality. Now that leads me to the last piece of research I want to present from Scotland, and that is their caring and quality measure. We had tested Watson's 10 dimensions of Caritas, and we had surveyed about 1,000 patients, and we found that it just was not a psychometrically sound theory to utilize. So we switched to Swanson, and we tried Swanson's 18-item measure of caring behaviors, and we found that also did not fit. It was a better fit, but it still wasn't psychometrically sound. So we utilized the 7 C's, they call it, from the National Health Service of Scotland, and we utilized their 7 principles of compassion or caring and integrated that into what did work from the Swanson measure. There were also a couple global items that they felt were important for caring, such as having the patient be involved in care, that making sure the environment was satisfactory, and that the faith needs were met. So we examined 1,096 patients in this data set using factor analysis. And what we found is that it was a psychometrically sound instrument to utilize in the context of Scotland. We found that there was 7 dimensions, the C's, all loaded together. We found that the Swanson items loaded together as the third subscale, and then we had 3 items that were more global that also loaded together. It had good model fit and good reliability, and this is what we currently used in our international study. So it's important when you measure compassion or caring, as we are doing in this international study, that it is tested psychometrically for both validity and reliability. In Turkey, they also have utilized the HES twice. They tested it first in 2017 and then in our study here. And in Turkey, we found that it was a statistically significant change in their job satisfaction in every variable except for satisfaction with resources and distributive justice. Now, what we talked yesterday about, if you correlate the global item of job satisfaction or a composite measure of job satisfaction, which would be like 11 items instead of 57 items, and then, of course, the 57 item, which is the facet measure for the HES. But in correlating the facet measure, the very long one, with either the composite, the 11 item, or the global, the 1 item, and you find a low correlation, in this particular instant, we found a correlation of 0.68, and you would, to say it is measuring the same thing, you would want 0.80 or greater. But we wanted to know if there was anything that was missing from their measure of job satisfaction. Before I talk about the thematic analysis in identifying possible missing variables, these are the scores for Turkey using the HES in 2017 and 2019. You can see just by looking at it that there were some dramatic improvements. Every variable, the only 2 that were not statistically significant, as identified already, was satisfaction with resources and distributive justice. We can note that the highest variable on average for both years was patient care, but the variable that made the biggest jump and to the lead variable in this most recent measure was satisfaction with the unit manager, referred to as participative management. Now, this is the question. We had 2 questions at the very end of the HES so we could do some thematic analysis. And there was 3 researchers who used inter-rater reliability to come to consensus of these themes being agreed upon. If there was a comment that we did not agree upon, we categorized it as miscellaneous. Here you can see that there was 125 no responses to the question, what adds to your job satisfaction, that was not addressed in this survey. So 125 did not feel there was something else that added to their job satisfaction, or they just simply did not respond. But we see that 43 people, for example, stated that they would have liked to talk about how being able to help makes them enjoy their job. Other was things that were they were either too isolated and unique, or they had commented in such a way that we were not able to theme. They just said patient, and we don't know what they meant about patient, or they just said coworker, and we didn't know what they meant about coworker. So, but if there was enough of a comment for us to theme, we did. The next most common was watching the patient heal and or be discharged. So observing good outcomes as well as satisfaction of the patient. So those things that relate to helping or watching outcomes of patients were the top 3 variables that they reported they would have liked to have talked about. Now, we do have relationship with the patient, specifically care planning, collaborating, coordinating with other disciplines, and continuity of care, but nurses here are asserting that they would like to have talked more about the emotive or the healing aspect of the care. The other question that we asked qualitatively and themed was, what could be better in your current job that would increase your job satisfaction? So here you can see the most common after no response was workload and lack of personal or resources. So those things that help them do the job that they don't feel that they have, like time or resources, were the most common issue that they wanted to report. Now, this next study that we did that helped us build our international model that we tested in 2019 was conducted in Jamaica. This was the first time that we actually looked at clarity, and we proposed that it made a difference in job satisfaction. Now, before we would proceed with testing clarity and job satisfaction and the associated hypothetical relationship, we had to conduct an exploratory and confirmatory factor analysis. And this is the confirmatory factor analysis. Because the HES had been tested so many times, we actually used parceling of data. We only had 87 people in our sample who completed the entire survey. So I had to utilize some method that could still utilize a small sample, but still proceed with a confirmatory factor analysis. In most studies, you would need a 400 sample for conducting factor analysis, but utilizing parceling of data, you can use a much smaller sample. And if any researchers on this call would like to learn how to do that, if you've not done that, let me know and I will help you, walk you through that. But here we can see that all the dimensions of the healthcare environment survey loaded together, it was a good model fit using RMSEA. I won't go into explaining that, but it was good model fit. And we can see that the highest loading item here for social was relationship with the coworkers, followed by as 0.72. The next factor loading was relationship with the medical doctor, which was 0.70, followed by engagement with manager, and then the patient, 0.52 and 0.35 respectively. When I asked our colleagues in Jamaica, why is it that the patient would be loading last, she had stated it's because here in Jamaica, it is we deliver care as a village. If the relationships with the physicians, the coworkers, and the managers aren't in place, patient care is not going to occur. So contextually, she was able to interpret the findings of these data. You can see also that the technical dimensions also loaded nicely together. The most important technical dimension was their ability to execute their knowledge and skills in the way they deem fit, which is what we would call autonomy, followed by workload, the WL, followed by professional growth, executive leadership, resources, and distributive justice, and last, scheduling. Now, this is the model that we tested that we had hypothesized would be important, and you see that it's very similar to what we tested internationally. The only difference is clarity of self-concept was not included in this study because the theory proposed by Jane Felgen, Jane and I created the clarity of role and clarity of system, but we utilized clarity of self-concept from another instrument, and it didn't quite fit. So we would eventually like to develop a clarity of self subscale for the clarity measure, and clarity of self as defined by Jane Felgen in essence is that one values one's skills and talents as well as understanding one's vulnerabilities, but being okay with that and maximizing your talents within the team. This was the actual model. So we can see, just like our 2019 study from this year, that clarity of role and clarity of system both predicted job satisfaction, and the only professional demographic that we found was service line. Similar to how we found country predicted job satisfaction, we also found that different areas of care impacted job satisfaction. Now, one of the challenging things here in the United States as well as globally is the growing number of hospitals that are merging to survive financially, to share resources, but this also increases the complexity and ability to measure individual contexts and cultures. And within this system, they wanted to look at caring science, but they had recognized that they utilized several different theories of caring. There were 14 hospitals in this study, and these are the different theories that they were utilizing across these 14 hospitals. So this can create some challenges, but we were able to do it utilizing standardization. So they looked at Watson's theory of transpersonal caring. That is her original version of caring science. There was the more contemporary theory of Caritas from 2008. That is what I have done most of my research in. She has a more recent version called Veritas, which I won't go into, but you can read her most recent work on how that she continues to evolve in her thinking on caring science. The next one is Duffy's quality caring nursing model. This is premised upon much of Watson's work, but it has a different flavor for operations. Swanson's theory of caring behaviors, and finally Carolee Coates, who combines Watson's theory with Bandara's concept of efficiency. So you can see that Watson is in 4 of these 5 theoretical frameworks, if you will, or measures, and then there is Swanson, which was one of the 5. But this creates a challenge of how do we measure all of that and still have a conversation that makes sense. So we standardize them. So whatever, if it was a 6-point scale, we standardized to a 7-point scale. If it was negatively phrased, we would phrase it positively. They were all in the same direction. So after we had done that, we proposed this was our model that caring for self and job satisfaction would relate, not necessarily showing any direction, but also that job satisfaction would relate to caring for the patient as reported by both the patient and the staff. Now, the first model that we tested, we thought caring for self would relate to job satisfaction, and that job satisfaction would relate to caring as perceived by the patients. We studied 96 units, but only 33 units included measurement of the patient. Hence, we utilized unit level data and adjusted our alpha. So this didn't pan out like we thought it would. Let's see. Oh yeah. And so what we did is we actually added clarity to our model. Results from the respecified model, adding clarity, revealed that caring for self predicted clarity of role, 31%, and clarity of system, 14.7%, and clarity of self, 14.8%. Clarity of system had the strongest impact on relationship with job satisfaction at 42.9%. This is similar to our international study, what we found. We also found that clarity of role and clarity of self, which predicted 3.8 and 2.7% of the variance of job satisfaction, respectively. So as you can see, this is looking much like what we found. Clarity of role and clarity of finally, caring for the patient predicted 15.9% of the variance of job satisfaction. The only demographic that interacted with this model was partner status, with those who reported being married or domestically partnered conducted less caring for self than those who were not partnered. And that predicted 6.5% of the variance of caring for self. This model of caring for self predicted clarity, which subsequently impacted job satisfaction, and this is consistent with the model that we reviewed yesterday and from the international study of our 5 countries, which was just over 2,400 nursing staff. Now we have 2 more studies that I'm going to review, and then we are going to just take a short break and then talk about predictive modeling and how we might integrate caring science into outcomes, as well as talk about next steps. So this particular study, we used hierarchical regression to examine what variables related to and predicted the caring connection between the patient and staff. There were 542 nursing staff in this study, and it revealed that the variables explained 41.3% of the relationship with the patient as reported by the staff. Caring for self explained the largest portion of the variance, explaining 26.2%. Primary nursing, or connecting to the patient through collaboration with other disciplines, care planning, continuity of care, and relationship with the patient, that explains 6.7% of the variance. And the 4 aspects of and clarity of role explained 5.5% of the variance. Being a direct care provider also explained variance, but that was only 2.2%, which is not surprising since relationship-based care proposes that everyone can create a caring moment, and thus the direct care provider wasn't as significant and not too surprising. Now, the last model I want to talk to you before we just take a 5-minute break is we wanted to look at civility. This particular hospital, and I identified the source for each of these studies in one of the slides for each study. So here you can see we have published this one in the Journal of Partnership Studies in 2017. Some of the other studies, I just want to go back and tell you, is we have a new book coming out, and this one, for example, Kate Takis, Tricia Thomas, Gay Landstrom, and myself, we were the authors of this study measuring the context of caring in a multi-system health organization. And that's in our new book coming out by Springer. It should be out in December. And it's called Improved Outcomes in Nursing, an Evidence-Based Guide to Relationship-Based Care. And we look at outcomes of the employee, outcomes of the patient, and the 3 principles of how data can be utilized effectively to change operations, and that is theory, data, and then collaborating with operation people. So researchers and operations should collaborate. So that's a book I want you to just to know about that's coming out. But this particular study, this hospital, they said, you know, John, we have a couple units with some bullies on it, and we would like to study this. And we think, we have a hunch, because I tell people, if you're not into theory, just tell me your hunch, because that's really theory in its most simple form. So I said, tell me your hunch, and they said, we think bullies make a difference on clarity, and we understand that clarity is very important. So we looked at this, and we used Kathleen Bartholomew's theory of civility. She's got a couple books out on this. And Ms. Bartholomew identifies that in order for us to navigate bullies and to conduct ourselves civilly, we need to not only be taught this in school, but also to observe it from our professors and our instructors. So this was our hypothetical model, that instructors who demonstrate and teach civility help nurses understand how to navigate bullies and to act civil, which impacts their clarity, which then impacts job satisfaction and outcomes. We found this to be true. We found that education of civility and the behavioral demonstration by the academicians predicted 27% of civility as reported by the nurses in this hospital. We also found that those who reported they understood civility and knew how to navigate bullies, that helped them become more clear in self, role, and system. This predicted 26% of clarity. We also proposed, as we have tested in our international study, what the impact of clarity is on job satisfaction. Now, what's fascinating to me is in our international study, we found that clarity of system was most important. In the previous studies, in the 96 hospital system, we also found that clarity of system was important. Here we found at this hospital, it was clarity of role that was most important. So it depends on where the staff are as it relates to their understanding on role. Specifically, what are their independent, what are their interdependent, and what are their dependent functions within their role. If they don't understand each aspect of that role, there will be confusion in interacting with their coworkers and within the system, and it will add to their workload. So what we found interesting is that it is not always the same order of clarity that impacts job satisfaction. So this was very useful to this organization in understanding what to teach and what to address as it relates to job satisfaction. We also found too, just like our international study, is that job satisfaction does impact perception of caring. This was the employee's perception of caring for the patient, and job satisfaction predicted 32.9% of what predicts caring as perceived by the patients. So those who had greater job satisfaction, socially and technically, were more connected to the patients. All right, we're going to transition to the next PowerPoint. It is now 9 after the hour. Let's reconvene at 15 after the hour, and we will resume with our predictive analytics and how can we integrate behavioral constructs into our proactive management of outcomes. Currently, we do retrospective management, but we would like to move to proactive management. All right, so I'll see you in a few minutes. This next part I'm really excited to talk about because it brings us deeper into really the outcomes and about the next steps that this large study that we're doing right now. I think we can do some really important stuff as it relates to the quadruple aim. Okay, and the Caring International, just in quick review, the Caring International Research Collaborative was started in 2005, and it is in its third iteration. Originally, it was a collaboration of researchers. It was started by Jane Felgen, Geraldine Murray, and myself. And we did a lot of research in caring science and relationship-based care. And it didn't take long after the first 2 years, and within that time I had started working with Dr. Watson in lots of studies. And within the first couple of years, we did about 75 research studies, and it was so many I couldn't keep up with the publishing. So Jean and I put 45 of those studies into our book, Measuring Caring. That was 71 collaborators in 7 countries. So that was our first publication. That got the notice of Sigma Theta Tau, who adopted us for about 6 years, and that grew to about 1,500. Not all really active like this group is, but we separated very amicably, of course, this last January, and we're each doing our own thing. And so this is a new iteration of CIRC, and this time it is the most active I've ever seen it. Everyone is really taking their content expertise and developed measures and networks and really doing some impressive research. So we're really excited to present that and talk about the next steps for our group. So the 2 principles for CIRC are bring a study to share, and it's about service, not self, so drop ego at the door. So those are 2 primary principles in CIRC. Now, I want to talk to you a little bit about the identifying the context and evidence. So really predictive modeling, we call it contextual analytics because people really bastardize that word, predictive analytics. And we do use predictive analytics, but it's really contextual analytics. So the first thing we do is develop the model. So we put the outcome of interest in the middle. We then circle that outcome with all the things we think relate to it. So we develop a model that's specified using both the evidence and the context. So once we have built that model for measurement, then we begin to collect the data, to interface, and to extract. Now, currently we are in the data collection phase using a lot of manual processes, but we would really like to leverage all of the technology and databases that are out there, even like geodata, such as zip codes, things that provide a lot of information that are publicly available. So we would like to move toward a more technology-friendly and automation and real-time reporting, and then we move toward the analysis of the data. Now this study, there's 2 predictive models I want to review with you. The first one is an international study we did on falls, and it was moved to Henry Ford decided to take that on and really study it deeply, and we really improved their fall rate and saved a lot of money, which was good. but it really took intention from the data collectors to do that. So the international study, it started with a discussion of executives from 5 hospitals in 3 countries, Ireland, Scotland, and the USA. And we identified 22 outcomes that were panic points. So we looked at things like falls, pressure ulcers, infection, hospital-acquired infections, readmissions of heart failure. So there were many things that were of concern as it relates to reimbursement, payment, and of course, outcome for the patient. We looked at 1,005, and it was falls that was the most important. We used criteria for what cost the most money, what cost the most resources, what do we know the least about, and what are we most stressed about. So we used those 4 items to score all of the 22 items, and falls came out as one of the top 3. So we decided to study falls. Now, in order to study falls, you have to study non-falls. Well, we didn't have the same data for the non-fall patient. We only had fall patient data. So we decided to look at injury versus no injury. So we have looked at 1558 falls, and 356 of those had injury, and 984 of those had no injury, and 218 did not report their injury status. Now, these are all the data that we looked at. Ah, that's so busy. But what I want to identify for you is the blue. These are all the variables we looked at, and here's the key. So the blue filled are those hospitals, those data that had all 5 hospitals that provided the data. So data was provided from all 5 facilities that relates to what hospital, what unit the fall occurred on, what year it occurred on, what month it occurred on, and what day. So you can't do a predictive analysis on facility, unit, year, month, and day of month. So it was easily identified that our data is too incomplete to study this, and we're all studying different things, not the same thing. So we couldn't do the international study. So Henry Ford stepped forward and decided we'll study it more deeply and share with the group. So Henry Ford, they decided to look at 163 non-fall patients and 170 fall patients. So we could regress the non-fall patient or the fall patients on the non-fall patients, of course, using regression analysis. These were all the variables that were in our model from the international study. So we didn't necessarily utilize the literature and or the context. We utilized the model that we had developed for the international study. So these were all the things that they were looking at internationally. There were a few variables, I think it was 10, that we found. Yes, it was 10 variables that correlated with falls, either negatively or positively. The things out of all of those items that related statistically significant were diagnosis, mobility, last fall score, what area of the hospital they were cared for in, the toileting process, their cognition, their admitting fall score, whether they had a bed chair alarm on, that actually increased falls, if they were on a diuretic, and if the patient was educated in fall risk. Now, what was most informative about this process, I'm going to talk about the final model in a minute. We were able to explain 35% of the variance of falls. And this is what I have found over and over again when we use models specified and complete using the literature and the context. People think differently about falls once they use an evidence-based process that integrates both the evidence and the context. Because, for example, we found that bed placement had a positive relationship with falls, but it wasn't in the direction that we discovered. We found the closer the bed was to the bathroom, the more likely they were to fall. And this was true sequentially for bed 1, 2, 3, and 4. So bed 1, closest to the bathroom, had the highest risk. Bed 2 had the second highest risk. Once you placed them in bed 3, there was no risk, and bed 4, there was also no risk. So instead of placing them closest to the bathroom, we started placing them furthest from the bathroom. The reason is because the patients thought, well, that isn't very far, I can make it there, but not considering I'm sick, I'm weak, I'm not eating like I should, and so they discover by the half the way to the bathroom when they fall on the floor that it was too far. So this was very interesting, and over in our discussions, we found things that we thought heuristically were true, but empirically we found were false. So we found that diagnosis predicted 19.3% of the falls, 11.2% predicted the falls, and then 4.5% of the last fall scores. Now, what was interesting about this is we found that, for example, the suicide patients, we found 9 of 9 had fallen. And what was interesting about that is in the conversations when we talked about it, it was discussed it's because they're on so many medications. And I'm going to come back to that in just a second, because that was really an important variable when we re-specified the model to understand falls more deeply. We also found that those who were up with minimal assist were also at risk. That was the biggest variance. You can use coefficients in your regression equation to identify the specific dimension of the construct or variable that you're examining. And we also found last fall score. Now, this was also interesting. They were using a 4 items fall risk assessment. So essentially everybody was at risk. So we moved to a 27-point fall risk assessment. And we found that the highest risk for falls was between 13 and 17. So it changed the operations to go from relying on chair alarms and sitters, which actually increased falls, to things like thinking critically. So we placed the last fall score at the end of the bed, so when the care providers walked into the room, they could see what the risk score was. So once it climbed from 9 or 10 to 13, it was at that point that the interventions began, but they were using their critical thinking. So at that point, they would educate the patient. We found this was important, and I talked about that in just 2 slides previous. If they educated the patient on their risk for falls, the patient was more compliant in staying in bed or following the rules, because the patient did not understand that their sickness was actually increasing their risk. So all these variables started to work together, and combined, we decreased the falls 4-fold. And we saved about 1.6 million in this process. And I should say too, this study is in our book that's coming up. Where is it? Well, it's in the relationship-based care one. So we are publishing this study. I thought I had the reference here. Sorry about that. So what I wanted to say before I go into that advanced model, respecified model, here in the diagnoses, what we talked about was the number of meds they were on, and the patients just were woozy or dizzy or whatever word you want to use, and it was the psychotropic drugs that these psych patients were on. So I decided to take another look at it, because there were about 15 drugs, specific drugs, and I had looked at, I think, maybe 10 of them, and I found no difference in any of them. So I actually quit too early in looking at this, and I went back to the data and I looked at the psychotropic drugs, and I found that there were many psychotropic drugs for patients who fell on the med-surg units and other units outside of the psych department. It was actually so profound that it became, when I looked at psychotropic medication, that actually replaced diagnosis. And it explained 34%, but it actually made the model better using the same data. So, and it made more sense from a operational standpoint. So we moved from 35% explained variance to 61%. So here we could see that the psychotropic medication explains 34%, mobility still 16.3%, but look what we've added here, educating patient in the fall risk. So it helps the variables or the items that you're measuring to play together more appropriately so that they relate in a more specified model. And then you can see that in the last fall score, that still predicts about 4.6%. But this is what's really important in presenting the data to the people who are experiencing or tending to that outcome, who can then provide proper interpretation so you can re-specify the model and take another run at the data. So for this particular hospital, my console would be to, whenever a person comes in with a psychotropic medication, to put them, to score them appropriately as it relates to fall risk. So this was very helpful. The second outcome that I want to talk about is hospital-acquired infections. Now, this is what I would call a specified model. It looks very busy, but it's the place you need to start. You need to start with the evidence, and the CDC from the USA has amazing data and has amazing guidelines for several of outcomes. If you need a empirically or scientifically sound source, the CDC has some really great stuff. They do a lot of weighting and a lot of stuff that I get going on mathematically because it's so good. But here, I want to take a minute to explain this to you. The key is over here. Any circle that is red, outlined, that is the highest level of evidence. So the CDC asserts this variable should be examined in your management of hospital-acquired infections, specifically central line associated bloodstream infections. So this is specific to CLABSI. The second level of evidence, as reported by the CDC, and you can find guidelines for almost most outcomes, like with heart failure, there are really good guidelines out there, etc. So start there. But according to the CDC, the second level of evidence are the orange outlined circles. So you can see there are several of these as well. These have some evidence, but we're not quite so sure. There was a third level that I didn't include here, and it was basically some say this is important, but I didn't include that because I just thought it got a little busy, and I want to focus on the priority of the evidence. Now, the last thing that I want to call your attention to is the blue-filled ones are the items that this hospital was collecting. So you can see that they were basically looking at the policy, the items in their policy on HAI prevention, and you can see that many of those items don't matter. There's a few of them that matter. But I think utilizing this approach of starting with a specified model for the outcome of interest is where we need to start, because it helps us understand, and putting this graphically was very powerful for the organization to see. So that's what we should measure. This is what we are measuring. Let's change our assessment process. So what we did in analyzing the existing data, we didn't move toward much of the other stuff, but what we used is the existing data, and what we found were some interesting things. With the existing data, we were able to identify, and here is the source of this study. It also is going to be in our book from Springer, coming out in December. And these are the clinical people that helped do this study. But what we found was UNIT predicted 22% of central line infections, and type of central line predicted infections, hospital-acquired infections. But again, like Henry Ford, this organization found that the conversation about the data is what really changed their management of outcomes and has really resulted in improved outcomes. For example, type of central line. We found in this organization that PIC lines were the highest incident of infections. That's contrary to the literature. The literature asserts that the PIC line is the safest. We also found that the femoral line was the safest, not the riskiest. This is also contrary to the literature. But it was the discussion of the operations and how they treated the evidence that revealed what was the cause of the outcome. We found that because staff perceived the PIC line based on evidence as being safe, that we could leave it in because we need it for blood draws. In contrast to the femoral line, that was identified as something being very risky, so we will only leave that in for a day or two, and only as long as we need it. We need to get that out as soon as possible. So the evidence was actually working against operations and the reported infections. So we have changed this. We are now working on identifying that dwell time is a very important variable and not just type of line. So be careful when you're proposing evidence that it is balanced with all the other aspects within the model. The second one was unit. It was interesting, we found a couple units that had up to a 4-fold likelihood that you would have an infection on that unit. Now, the unit with the highest, they had highest infection rates, they had great nurses, they had great clinical protocols, and they had passionate leaders who were very involved with their staff, so this made no sense to us. So we took these results and we had a conversation with the leaders and the staff of, let's talk about what is different about this unit. What we discovered is that was the only unit that had new lab staff. And it was actually that we discovered in inquiring more deeply from this conversation that the laboratory staff were actually not using the proper protocol and were actually contaminating the samples. So the infections that we reported actually weren't infections at all. They were contaminated samples. So this helped us guide us to the proper place where a normal conversation in a fish bone analysis or root cause analysis likely wouldn't have been revealed. So this was very helpful to utilize the data to draw it to the cause, quote unquote, of infection, where we could have a conversation about that cause, which didn't make sense to us. So this also had a dramatic improvement on CLABSI, and we saved, again, about $1.7 million. This will be articulated in this chapter. Now, these are all the variables that personally I have looked at in a specified way. So we have looked at vent-associated infections, falls, staff compliance, readmission of heart failure, job satisfaction, caring, opioid use disorder, chronic pain, CLABSI, length of stay. So all of these things I've done research, and every single time we've used model specification, data analytics, and conversation and respecification, every single time we've done this, we have saved up to $6.7 million on a single process. And the length of stay, that was the largest savings of $6.7 million. That's also in that book. So what I want to emphasize with this slide is, let's say, for example, we are measuring caring. We have some great data on caring. We have some great data on job satisfaction, but now we want to look at falls. Well, now that we already have these data and these variables are in our specified model for falls, we don't have to collect this. We already have this. Now we can just look at the other variables. So when you utilize this system for measuring and improving outcomes, the more variables you look at, these variables are going to overlap, the less data collection you'll need to do. A lot of it is manual right now, and we need to get better systems for that. Everybody complains about their EMRs. Everybody complains about their interfacing. Everybody complains about the redundancy of collecting. I do this globally. I've done it for 18 years, and it hasn't gotten better, even with the advent of the EMRs, and I would even say the EMRs have made it worse. Now, there's the other thing to think about besides the data that's in our hospitals. There's other data sources. For example, we have external data like geodata. So can we use the zip code of the patients and then go get publicly reported data on income, on socioeconomic type things, on family, on distance and resources in that community? So there's other types of data that we can utilize to augment our hospital data for more complete models, for more adequate analysis. Now, this is a really important slide. Healthcare is here. We're in deployment of research models, and we're really reactive. We haven't gotten over here to we're really utilizing data real time. When I was at a math conference about 4 years ago, there was 2 of us from healthcare. And I was sitting with the miners and with the truckers. They have great data because they manage their data proactively. So they actually manage their profile of risk, utilizing trajectories of mathematics and trajectories of outcomes to show, well, if this is our trajectory, this is where we're headed if we don't change something. So they move from linear regression to odds ratios, which is really risk. So when I went to this study and they were talking about the millions of dollars that they save proactively, understanding their staff and understanding the equipment that we're using and the systems, they asked me, John, how is it you in healthcare proactively manage outcomes? And I said, well, when a patient falls, we go and talk about why they fell, and we try not to do that again. And so they thought I misunderstood their question. And so they said, no, we mean, how do you proactively manage it? And I said, yeah, we when a patient falls, we go and talk about why they fell, and we try not to do that again. And it was fascinating from mathematician to mathematician talking. They said, you mean you don't do proactive management? You don't use profiles of risk for proactively managing your outcomes? And I said, no, we talk about why we shouldn't do that. And so it was fascinating for me. I mean, I was very excited because I saw the possibility of how we can use math, not just linear regressions and Gaussian, but how we can use outliers of success and failures like they did in management of CBAS, and articulating that made a difference. How do we use physics in high performance and looking at pause and flow? How do we use trajectories and patterns of outcomes to identify what our odds are that this is going to occur in the future? How do we utilize our explained variance as a real-time process to identify that our interventions are working and our model needs to be respecified? So mathematics, if applied appropriately with the conversation in operations, I think there's a powerful opportunity for us to not only measure what's important, but to measure the behaviors that are so difficult to measure. So that's where I think CIRC is what's so exciting for me. Is it's easy to measure machines and medicine, but it's difficult to measure behavior. Everyone on this call or listening to this presentation is likely to agree with me that it's the behavior of the staff, not the equipment they're using, that makes the difference in the outcomes. We in CIRC are seeking to understand how to measure caring, clarity, job satisfaction, and those elements that are important to be enacted on our patients. So it is my desire for collaboratively, as we refine the science in different constructs and different tribes, if you will, how can we work together in different content expert groups to build models that are specified and accurate and interpreted to move from our reactive stance to really proactively managing our falls even before they occur. So with that said, I would like to propose a few next steps. Now there's a few that are in process in CIRC, and there are a few that we're considering. So the steps for CIRC that are in process: first, we've finished the 5-country analysis, the preliminary analysis that I presented yesterday. And if you want that recording, just email me at jn@hcenvironment.com. And I'll send that to you. We have 3 countries that are completing their data collection: Brazil, Canada, and Israel. And we have our colleagues from Jamaica and England who have postponed till 2020. So we're excited that they're still in this, but they just need a little more time. So July and August, I will analyze the data from all 8 countries. In September, I will present the data to Brazil, Canada, and Israel so that we can interpret the findings and have a discussion on how we might respecify or intervene. And then finally, in October 28th and 29th, we will be presenting the final results as well as talking about next steps. And then on the 30th and 31st, we always take time to experience the culture and to do some informal networking and connecting and debriefing of the first 2 days. So it's a lot of fun and it's a lot of professional reward in that. So we would welcome anyone that's on this call to come join and to help build the science of caring. Also in process we're interpreting the data and we're developing interventions. For example, in Slovenia, there was a discussion, Nika and I reviewed their data, and there was an identification of some distress with the relationship with the physician. Well, it takes about a year from the time you do the study to when the intervention is implemented, because you have to collect the data, you have to analyze the data, you have to present the data, you have to interpret the data, then you plan for an intervention, then you make that realistic operationally, and so by the time you finally from study to implementation is about a year. Well, we would like to decrease that time. So one of the things that has been proposed in our group is to actually identify those interventions that we have tested and that have worked in various contexts. So I had proposed, for example, one of the studies I did in Kansas City in Topeka years ago, I found the same distress between the co-workers and the physicians, and I said, well, let's use appreciative inquiry and find out what's working, what's not working, and find common ground. So we found that the physicians were very frustrated that they were being called in the middle of the night and the nurse was not prepared for an clinical discussion that helped the doctor understand what was needed. And the nurse was frustrated because they were hung up on, or they were treated rudely or yelled at by the physician. So what we decided is, if the nurse had all the appropriate clinical information prior to calling, even though that sounds simple, it's a simple intervention that really helped. So we created a template, and it was, before you call the physicians, have all of this information ready so that when you call them, you can say what you're looking for, what's the supporting evidence for that request, and then have the doctor respond to what that need and articulated argument was. That was very helpful. The nurses were no longer hung up on and disrespected, and the physicians were so appreciative that the nurses were calling prepared. So how can we test these kinds of interventions that we can replicate and share with one another within CIRC? We are also looking at other hospitals to replicate this current study. We will plan to do this in waves. This first 8 countries will be leading the way in some of these studies, but countries that are wanting to be involved in 2020 is, of course, I've already mentioned, England and Jamaica. The Philippines has also gotten approval to proceed, and we are evaluating Austria and Croatia as well as others. So if there are countries that are listening to this recording and would like to be involved, please do contact me and we'll get you looped in. We are also inviting existing systems in our current study, if they would like to expand to other hospitals, that we would welcome that as well. So this current wave of hospitals and interventions, the 8 hospitals now, we would like to go deeper by respecifying the model or looking at context-specific things. We're going to be discussing that more over the next months, and especially when we meet together in Antalya, Turkey. Also in process is, since this is the 3rd iteration of CIRC, we need to redo our website. So we are currently looking at logos and websites. That will be up by the time we get to Turkey anyway. We are also developing new instruments, this group is. So one of the groups led by Dr. Michael Graham, he is from St. Catherine's in St. Paul, Minnesota. They are wanting to look at caring of faculty. And they're not only interesting because we have found that caring of manager, as reported yesterday, impacts the nurse. St. Catherine's, being based in caring sciences, they also believe that caring of the professor or the faculty impacts their students' clarity and success. So they not only want to look at caring of the professor in the classroom, but also the clinical instructors, the preceptors, etc. Now, some of those tools are already in place, like caring of the preceptor. That's in my book with Gene Watson from 2012, Measuring Caring. And then we need to develop, we have developed the caring of the professor, which we're currently doing some content that we've done phase and content validation. Now we're doing some construct validation, but then we need to amend it for clinical instructor, etc. So we want to have an array of an evaluation of the caring behaviors of all those who instruct students. We also have an expert in comfort Tara Nichols. And this is really beyond pain. It's a very interesting. She uses COCABA as well as caring sciences and relationship-based care. And she calls it the Nichols-Nelson's model, since I helped her develop that psychometrically. But this assessment is really good for people that are in chronic pain, who are opioid or use disorder, who have things like shortness of breath, and it's not really pain, but it's discomfort. It's a really amazing model that integrates caring sciences. So we are moving forward with deeper assessment in that. We are also developing a nurse residency assessment that will be utilized for the new nurses, and we're looking at both again, like the academic setting, we're looking at the preceptor, the mentor, sort of the whole experience of that residency program. We're also using these data for secondary analysis. We would invite students, if they would like to take another look at our data at any of them demographics, we would be open to discussing that with any students. Currently, Turkey and Slovenia are using these data to look at the difference and similarities of Turkey and Slovenia. We are also looking at how we can use the data for curriculum development. St. Catherine's is interested in this, as well as Donna Cato. She is interested in this in China because there's a lot of curriculum development going on there, and she would like to use the evidence to actually drive that development and bridge the gap between academia and practice. And then finally, we need to evaluate where we might publish all of these data in what journals, etc. We are looking at using the existing data. This one I'm really excited about. We have 176 units in this current study right now, the five countries. We think we have about 250 units, which is a nice sample. And we're going to look at how job satisfaction, clarity, and caring relate to sick time and turnover of the patients. But this sample is really large enough at the unit level data to look at infection rates, falls, pressure ulcers, etc. So after we conduct this study, we will likely, we will be evaluating how can we really prove or test the quadruple aim even at the patient level. We would like to work with other engineers for how can we work with other data sources for automating this to real time. One of my dreams is to be able to utilize the data for proactive management of staffing. So you could actually look at the profile of the staff that you have, and when you do your scheduling, that you could connect that to the outcomes of your unit and say, okay, I don't have enough clarity, I don't have enough certified staff, so you would be able to evaluate in real time as you do the schedule what the safety of your staff is. Now that's a little ways down, but we could do that if we are able to collect names and look at that data in that way. We're also looking at tribal possibilities. This is from Wayne Clancy. And one of the things he talks about is in strategic planning, we don't do a very good job in aligning prior to strategic planning. What we tend to do is come forward with what we think is going to work instead of stepping back. For example, we have in the US, we have the licensure examination after the 2 or 4 years of nursing education, assuming that that is the standard of safe practice. Not all countries do that. Some countries have just lots of clinical training. They have a lot of educational hours. They don't do the same licensure exam, but they have a very rigorous and respectful process for assessing clinical competency. So if we step back and look at what we all want and then evaluate the different methods that are utilized, we can really do an appropriate analysis for what is the best outcome and maybe even course correct in some of our thinking. The other thing we've been talking about is compiling these data and these studies from this original baseline study into a book that would really address the quadruple aim. So that's in discussion as well. We would like to establish the meeting venues 3 years out. I know Scotland would like to host us. I know that in China, Shanghai, they would like to host us. Jamaica, we were hoping to have that this year, but we have postponed that for another year. So we have many people that have requested to host CIRC, so we will put that 3 years out so people can plan accordingly. And then finally, we would like to promote the content content expertise of those within CIRC. So that is really a tribal sharing or a group sharing of what our expertise is. We don't all have to do the same thing. We don't all have to know everything. So how can we leverage each other's content expertise to build a scientific database that is really meaningful and that can be used for outcomes management? All right. Well, that was a lot of information, I know, in our almost 2 hours together, but I'm going to open this up for discussion. Are there any comments or questions?